Hello, my friends. I'm Dr. Rachel Storms, and today I want to give you something most people never get in a short doctor's appointment. A clear, evidence-based answer to one of the most common questions patients ask me, but rarely get a thorough response to. What is the best time of day to take your blood pressure medication? If your physician told you to take it in the morning and that was the end of the conversation, I want you to stay with me, because the science on this question has shifted meaningfully in the last decade, and the answer for Lisinopril, Amlodipine, and Metoprolol is more nuanced than a single answer can capture. I want to begin with something important. Taking your blood pressure medication at the wrong time is not simply less effective. In some cases, particularly for patients with the cardiovascular risk profile typical of adults over 65, the timing can shift outcomes in ways that matter clinically. Studies tracking thousands of patients have shown measurable differences in cardiovascular events depending on when these medications are taken. This is not a fine-tuning detail. This is a meaningful variable that you can adjust at no cost and with no additional prescription, simply by understanding what your medication is trying to accomplish and aligning its peak effect with the time your body needs it most. Before we go further, I want to address something directly. Nothing I say in this video is a recommendation to change your medication schedule unilaterally. If your physician has told you to take your medication in the morning, that recommendation may be specifically tailored to your situation in ways that I cannot know from outside the room. What I am providing today is the framework and the evidence base that allows you to have a much better conversation with your physician about whether your current schedule is optimized for your specific physiology. That conversation is worth having. The change, if any, comes from that conversation, not from this video. Let us start with the foundation that makes the timing question matter at all: the natural circadian rhythm of blood pressure. In a healthy adult, blood pressure follows a predictable daily pattern. It rises in the early morning hours between roughly 4 and 8, peaks during the active part of the day, and then drops during the evening and into the night, with the lowest values typically occurring between midnight and 3 in the morning. This nighttime dip is not a flaw or a sign of weakness. It is a cardioprotective adaptation. The vessels relax, the heart rests, and the mechanical stress on the cardiovascular system is reduced during sleep. We call this normal pattern dipping, and adults who maintain it are described as dippers. Now, here is where the clinical implications become serious. Some adults, particularly those with hypertension, diabetes, kidney disease, or sleep apnea, lose this nighttime dipping pattern. Their blood pressure stays elevated through the night, sometimes nearly as high as during the day. These patients are described as non-dippers. And the clinical significance of being a non-dipper has been documented extensively in cardiovascular research. Non-dippers have significantly higher rates of stroke, heart attack, kidney damage, and cardiovascular mortality compared to dippers, independent of their daytime blood pressure readings. The night is when the damage is happening. The day is when the readings get measured. There is an even more concerning pattern called reverse dipping, where nighttime blood pressure is actually higher than daytime pressure. Reverse dippers carry the highest cardiovascular risk of all. And here is the part most patients have never been told. Standard office blood pressure measurement, taken once during a daytime visit, cannot detect non-dipping or reverse dipping. The condition is invisible to the standard care most patients receive. It can only be identified with ambulatory blood pressure monitoring, a device worn for 24 hours that takes readings at regular intervals around the clock. I use an analogy that helps my patients understand this. Your heart is an engine. During the day, it runs at varying speeds depending on what you are doing. At night, it is supposed to drop to idle, giving the moving parts time to cool and recover. If the engine never drops to idle, if it runs at near cruising speed all night, every night, for years, the wear accumulates. Components fail earlier than they should. The damage is not from any single moment of strain. It is from the absence of the rest period the system was designed to have. This is what non-dipping is doing to the cardiovascular system, and it is why nighttime blood pressure control is now considered by many cardiologists to be more clinically important than daytime control. This framework is what makes the timing question consequential. If your blood pressure is high at night, taking a medication that peaks during the day is providing protection at the wrong time. The medication is working, but it is working when you do not need it most. Taking that same medication at a time that places its peak concentration during the overnight hours can directly restore the nighttime dipping pattern and reduce cardiovascular events. Let me now take you through each of the 3 medications specifically. I will start with Lisinopril, which has been the focus of significant chronotherapy research in recent years. Lisinopril is an ACE inhibitor with a half-life of approximately 12 hours, which means its concentration declines by half every 12 hours after a dose. Taken in the morning, Lisinopril provides maximum effect during the daytime hours, with its concentration falling considerably by bedtime. Taken in the evening, the medication provides maximum effect during the overnight hours, supporting the nocturnal blood pressure dip in patients who have lost it. A large Spanish study called the Hygia chronotherapy trial, which tracked over 19,000 hypertensive patients for an average of 6 years, found that patients taking their blood pressure medications at bedtime had a 45% lower risk of cardiovascular death, heart attack, stroke, and heart failure compared to those taking the same medications in the morning. The findings were striking enough to change clinical practice in many parts of Europe, although the trial has been subject to ongoing methodological debate and the picture is not yet fully settled in American cardiology guidelines. What is clear is that for patients who have documented non-dipping on ambulatory monitoring or who have characteristics that make non-dipping likely, evening dosing of Lisinopril is increasingly recommended. The conversation with your physician is whether you fit that profile. There is one important caveat for Lisinopril dosing that needs to be part of the conversation. Lisinopril can cause a dry cough as a side effect, and some patients find this cough more disruptive at night. If you are on Lisinopril and experiencing significant cough, evening dosing may worsen the symptom, and a switch to losartan or valsartan, which produce cough far less often, may be appropriate. This is a specific issue worth discussing with your physician. Amlodipine is the second medication, and the timing considerations are different because of its pharmacological profile. Amlodipine has an extraordinarily long half-life, between 30 and 50 hours depending on the patient. This means that once you have reached steady state, which takes about a week of consistent dosing, the medication's concentration in your blood is relatively stable across the entire 24-hour cycle. Unlike Lisinopril, which rises and falls meaningfully within each dosing interval, amlodipine essentially provides constant concentration once you are at steady state. The timing of when you take it within the 24-hour cycle has less impact on its blood pressure effect than is the case for shorter-acting medications. This does not mean timing is irrelevant for amlodipine. There are 2 specific timing considerations that do matter. The first is the peripheral edema, the ankle swelling that is one of amlodipine's most common side effects. Edema tends to be worse later in the day, as fluid accumulates in the lower extremities during upright activity. Some patients find that taking amlodipine in the evening, closer to when they will lie down for sleep, allows the redistribution of pooled leg fluid to occur, while the medication's peripheral vasodilatory effect is at its peak, which paradoxically can reduce the perceived edema burden compared to morning dosing. This is not universal, but it is worth experimenting with under your physician's guidance if edema has been a problem. The second consideration is the consistency of dosing time, regardless of which time you choose. Because amlodipine has such a long half-life, missing or significantly varying the dosing time produces less dramatic effects than with shorter-acting medications. But for the long-term stability of blood pressure control, taking amlodipine at the same time every day, whatever time that is, produces the most reliable readings and the most predictable medication management. Inconsistency in timing is more problematic than the specific choice of timing. Metoprolol is the third medication, and the timing considerations are again different. Metoprolol comes in 2 formulations that need to be distinguished clearly. Metoprolol tartrate, which is short-acting and typically dosed twice daily, and metoprolol succinate, which is the extended-release formulation dosed once daily. For metoprolol tartrate, the twice-daily formulation, the doses are typically split between morning and evening to provide 24-hour coverage. The morning dose blunts the dawn surge in heart rate and blood pressure that occurs as you wake. The morning dose blunts the dawn surge in heart rate and blood pressure that occurs as you wake. The evening dose provides overnight coverage and supports the nocturnal dipping pattern. The interval between doses should be as close to 12 hours as possible. For metoprolol succinate, the extended-release once-daily formulation, the timing question is more open. Evening dosing has theoretical advantages for the same reasons I described with lisinopril, particularly for patients with documented non-dipping. However, metoprolol can produce vivid dreams or sleep disruption in some patients due to its effects on melatonin production, which I discussed in my previous video on beta blockers. Patients who experience this side effect often find morning dosing more tolerable, even if evening dosing might offer cardiovascular timing advantages. This is one of the cases where the side effect profile in the individual patient may outweigh the general principle. One additional factor for metoprolol specifically, the medication's effect on heart rate is more sustained than its effect on blood pressure, meaning that even when blood pressure has returned to baseline between doses, the heart rate effect remains present. This is relevant because for patients who take metoprolol primarily for arrhythmia control or for heart rate management after a heart attack, the timing question is less about blood pressure and more about maintaining consistent heart rate control. Evening dosing may be appropriate, or morning dosing may be appropriate, depending on what the medication is primarily addressing in your specific case. Let me say a brief word about the scientific evidence behind chronotherapy in cardiovascular medicine, because the field is still evolving and I want you to have an accurate picture. The HYGEA trial I mentioned generated significant excitement and influenced practice in many European countries. However, methodological questions about the trial have been raised, and American cardiology guidelines have not yet uniformly adopted evening dosing as a standard recommendation. The TIME trial, a large British study published in 2022 with about 21,000 patients, found no significant difference in cardiovascular outcomes between morning and evening dosing in a general hypertensive population, which has tempered the earlier enthusiasm. The current synthesis among many cardiologists is this. For patients with normal dipping patterns and well-controlled blood pressure, timing matters less than consistency. For patients with documented non-dipping, evening dosing of at least one of their medications appears to provide measurable benefit. Identifying who falls into which category requires ambulatory blood pressure monitoring, which not every patient has had. Before I close, let me give you the 3 specific questions to ask your physician at your next appointment. These questions are designed to open the conversation about timing in a way that gets you a thoughtful, individualized answer rather than a generic recommendation. First, do I have documented evidence of nighttime dipping or non-dipping? And if not, would ambulatory blood pressure monitoring be appropriate for me given my risk profile? This is the question that gets you objective data about what your blood pressure is actually doing overnight. Second, given my specific medications and my dipping status, is there evidence that evening or split dose timing might be more appropriate than my current schedule? This is the question that translates the data into a personalized recommendation. Third, if we change my timing, what should I expect in terms of side effects, and how should I monitor whether the change is working? This is the question that ensures you have a clear plan for evaluating any change rather than just hoping it helps. I want to say something honest about why I made this video. The question of when to take blood pressure medication is one of the most important decisions in the daily management of cardiovascular health, and it is one of the decisions that gets the least attention in routine appointments. The default of just take it in the morning is often a reflection of habit and convenience, rather than a deliberate choice based on your specific physiology. You deserve a more thoughtful answer than that, and the only way to get one is to ask the question in a way that requires more than a one-line response. This video gives you the framework to ask that question well. Share this video with anyone you know who takes a blood pressure medication. The timing of these prescriptions is something most patients have never reconsidered after the initial appointment, sometimes years or decades ago. A simple conversation with their physician, prompted by the information in this video, could lead to a meaningful improvement in their cardiovascular outcomes. And in the comments below, tell me what time you currently take your medication and whether you have noticed any side effects you suspect might be related to timing. The community of viewers here is large and informed, and the shared experiences in the comment section help everyone learn from each other. If you want to understand the specific morning routine that optimizes how your medication actually absorbs once you do take it, my video on the morning habits that affect Lisinopril, Amlodipine, and Metoprolol takes the timing question one layer deeper. Watch that video next.